So
Great.
welcome to the third webinar in the spring series hosted by the HRB Primary Care Clinical Trials Network Ireland. I will now introduce our host for today, Dr. Mark Murphy. Mark is a lecturer in the Department of General Practice in the RCSI, and he is also a GP in an urban practice in South Dublin. Mark graduated from UCD in 2005, and he also took part in the Sligo Specialist Training Programme in General Practice in 2013. He is currently participating in the HRB-funded Severe PhD Programme in Health Service Research. His PhD will address variations of chronic disease management in Irish primary care, specifically addressing clinical inertia in type 2 diabetes management through the targeting of poorly controlled patients. Mark is also an active member of the ICGP and the Irish Medical Organisation. So Mark, on behalf of the network, I would like to say thank you very much for joining us today and delivering this webinar, and thanks to everyone for joining in. So I will hand over to you, Mark.
Thanks very much, Martha. Can you hear me?
Yeah, we can hear you. Can everyone hear Mark okay?
Great. Well, it's a pleasure to be asked to present this webinar today, and I'd like to thank the HRB Primary Care Clinical Trials Network Ireland for facilitating this. I know many of the participants here, but for those who don't know me, my name is Mark. I'm a GP based in Dublin, and I work in the Royal College of Surgeons. And some of the presentation today reflects some of the work that myself and colleagues in the Royal College of Surgeons have been doing. So I'm going to be talking about a common issue for GPs, as we know, poorly controlled type 2 diabetes. It's a challenge, and I'm also going to talk about the DECIDE study afterwards. So the outline of the talk will over the next 30 minutes. Firstly, we'll talk about the new guidelines for diabetes from the Irish College of General Practitioners in the context of the diabetes cycle of care. We'll talk about medications. We'll talk about poorly controlled diabetes. We'll discuss a specific case of poorly controlled diabetes, and we'll finish talking about the DECIDE study. So moving on about the new guidelines in the cycle of care. So we know that diabetes is very prevalent. So almost 6% of the adult population and the patients in our practices have diabetes. And this is estimated to increase by 60% over the next 10 to 15 years. It's also very costly. So about 10% of the total healthcare budget is spent on diabetes, which we are managing. So, and about 60% of that spend is on the complications. And as you know, only too well, that relates to the microvascular and the macrovascular complications. So we now have a type 2 diabetes cycle of care, and that was agreed in October 2015. There were some politics behind this, and the ICGP were involved in terms of integrated guidelines. And before this, they removed themselves because of no funding, but funding was finally delivered for diabetes care, and that provided for biannual visits to support you to manage diabetes care only for GMS eligible patients. And we'll discuss this, and as part of it, you may have access to a HSE diabetes nurse specialist who may come to your practice or not. And to facilitate that, the ICGP delivered these guidelines, and huge credit must go to Velma Harkins, obviously, for developing these. So these are called Practical Guide to Integrated Type 2 Diabetes Care. So what are the kind of key aspects for us that we need to know about in these guidelines? I suppose the main thrust was that it was going to move from unstructured care to very structured care led by general practitioners. And this word integrated care was used. So GPs are the predominant healthcare professional managing this chronic illness, but there's a joint involvement at all levels of care to deliver better outcomes for patients. It specified very clearly what your role as a GP is, as the real leader in this, and specifically the role of the practice nurse and the role of allied healthcare professionals which support our patients to manage their diabetes effectively, such as diabetes nurse specialists, podiatrists, dietitians. There's also an onus on us to keep a register of patients, and what should be in that register is outlined very clearly in the guidelines. And there's a clear outline as well of changes in recent medications. And this is really what I'll touch upon a little bit today. One example of quite a complicated diagram from these new guidelines is as follows. So you can see at the top, we have someone who started metformin. We've increased the metformin to its highest dose. And because diabetes, because the HbA1c is still over 53, we now have an option to add a second drug. And that can get complicated based upon a variety of factors, based upon the patient's weight, the patient's preference, based upon your experience. And here we have 5 options which you can choose to add. And we'll touch upon this in a moment. We also have this concept of uncomplicated versus complicated diabetes. So, first question, what makes a patient with type 2 diabetes, in inverted commas, complicated as per these guidelines? A foot ulcer, raised creatinine or chronic kidney disease, diabetic eye disease, refractory, cardiovascular risk factors, or all the above. So I think we have a poll that we might be able to use, Martha, if that can be put up on chat.
Yes, yeah, one sec now. Now, so can people see that poll on their screen?
So, okay. Okay, so I think that's 6 out of 7. So 5 out of 6 have said all the above. So there's different definitions, which I think is quite important when we talk about poorly controlled diabetes in the moment. So I'll move on and we'll give the result in just a second. All righty. I'll have to go back to my presentation. Now, beg your pardon. I'm trying to share my PowerPoint. Hang on just a second.
Yeah, we have your PowerPoint, Mark. If you just go back into slideshow mode.
Okay, I don't have it in front of me though. I don't have my PowerPoint in front of me. So, great, I have it now. Thank you. So, what makes the patient complicated? Well, the guidelines, that's not, beg your pardon. I have, my PowerPoint presentation isn't available in front of me to visualize. Okay, so hopefully it works. So here we have uncomplicated type 2 diabetes. And uncomplicated diabetes, as per the guideline, can be managed by us in general practice alone without need for referral to endocrinology. So these are stable patients with a HbA1c less than 58 or 7.5%. They're on 2 glucose lowering agents, not an insulin. And really they've controlled cardiovascular risk factors and they're getting along well. And that's uncontrolled diabetes or uncomplicated diabetes. Complicated diabetes as follows are patients that really they might be on insulin, they're on 2 or more drugs and their HbA1c is over 7.5 and not coming down. They might have a foot ulcer, chronic kidney disease, they might have diabetes, diabetic eye disease, or uncontrolled cardiovascular risk factors. And the guidelines, which are just guidelines, but they would recommend that these patients should possibly be cared for with our colleagues in secondary care. So moving down here, really the answer here is all of the above, based upon the ICGP guidelines. But I think many of us in the webinar today would have different levels of experience managing diabetes, and some of us may be more comfortable managing some of these patients based upon their circumstances alone. A second question, a patient is on metformin and is overweight. Which medication would be second line in this situation? So I'll open this up as a poll, if possible, Martha.
Would everyone mind putting their answer in the chat? Just if we're having problems with the poll to get back up the slideshow, it might be best if we use chat to answer if we decide A, B, C, D, or E.
Okay. B, A, B. So that's interesting. So DPP4 inhibitors are being said, and then my preference would be A, but not acceptable to many patients. So A, B, and E are also said. So they're the newer agents. So no one said a sulfonylurea, such as gliclazide, yet. So that kind of reflects the guidelines that we've already put up, that there are preferences, and it depends on patient factors, maybe medications you feel more comfortable with, and there are certain contraindications. So really the guidelines would say that any of these drugs, oh, there it goes again. So really any of these drugs could be used as a second-line agent, depending on specific patient factors. For example, GLP-1 agonists and DPP-4 inhibitors are better in terms of being weight neutral. Sulfonylureas have longer data, but they may increase the risk of the patient putting on weight. There's an increased risk of urinary tract infections with answer E. And obviously with GLP-1 agonists, they're injected. So obviously the patient will have a preference there. And so really moving on, what we're getting at with medications is that there are a lot of new options and it can be quite complicated. So the guidelines are very clear, and I'll run through the guidelines here. With metformin, we know that that's the first line agent that we'd all use. And in the second column here, we can see the guidelines say that it's very effective, it promotes weight loss, and there's good long-term data. On the downside, there are some GI side effects, and it can be difficult to use in patients with chronic kidney disease. Certainly if the eGFR is less than 30, there's a contraindication. With sulfonylureas, the traditional second-line agent, although that has been changing recently, they're again very effective and there's long-term data. However, there is the hypoglycemia risk with sulfonylureas and the difficulty sometimes with weight. So moving on to pioglitazone. Again, it's a longer-term agent, and I myself haven't started anyone on pioglitazone as a second agent in the past maybe 4 or 5 years as a GP managing diabetes, but it is in the guidelines. There are some contraindications, risks in terms of bladder cancer and epithelial changes, and also a contraindication with heart failure, which has limited sometimes its use. Some of the answers for the last case involve DPP-4 inhibitors, and certainly they are very well tolerated. There's no hypoglycemia, and they're beneficial probably in terms of the weight profile, but they can cause some GI side effects, and they're advised to be avoided in terms of if a patient had a history of pancreatitis. In terms of GLP-1 agonists, again, they're very beneficial from a weight perspective. No hypoglycemia has been demonstrated, but they can cause some nausea and anorexia in patients, some bloating, and that possibly explains sometimes why they're beneficial from a weight perspective. Again, pancreatitis is a rare but concern, and it is an injectable. A newer agent, an example is Forxiga, is one trade name of an SGL2 inhibitor. They promote excretion of glucose from the kidneys. So they are beneficial from a weight loss perspective. They can be used as a second-line agent or a third-line agent, but they are a newer drug, and there is an increased risk of genitourinary infections and polyuria as glucose excretion is promoted. Insulin we may have different experiences with insulin, certainly in terms of titrating and increasing the dose. But if you want more information on this, the ICGP guidelines are very clear, particularly in terms of the three types of ways in which insulin are used. And many of us would know a patient who is on a once-a-day long-acting insulin, such as Mellitus. It's important, the ICGP say, that titration is key to success. And we should, as GPs, in conjunction with because this person will be complicated in the ICGP guidelines, in conjunction with hospitals, we should be able to increase and titrate the dose of insulin for our patients. Work that Professor Susan Smith and myself have done in diabetes in Ireland, we looked at the geographical variation of prescribing of these drugs around Ireland in 2013 and 2014. And this was published last year in Family Practice. So a question, and what I might do is I don't think I'll use polls or chat just for the moment, because I think I'm having a problem getting back in. So I might just get you to ask yourselves, which medication group do you think has the highest variation in terms of prescribing in Ireland? So what I'm getting at here is certain geographical parts of the country. Some places will prescribe more than others. And which drug do you think shows the greatest amount of variation? Is it metformin, sulfonylurea, a DPP-4 inhibitor, or the newer agent, a GLP-1 agonist, which is injected? So after thinking about that, I'll just provide you some of the summary results of of our study. So we show that the use of all anti-diabetic drugs has increased in 2013 to 2014, and diabetes is rising in prevalence, so that would be expected. We also saw that there's very high geographical variation in GLP-1 agonists, so that's really giving the answer. And there was moderate variation of DPP-4 inhibitors, but just not as much. So we don't know why there's wide geographical variation in the prescribing and the standardized prescribing of these agents, but we know it's there. And this is before the cycle of care was brought in, of course. So this is a geographical map of Ireland. So the red areas show those parts of the country with the highest prescribing rates of GLP-1 agonists, and the dark green areas show the areas of the country with the lowest areas. So it's very interesting why there's this significant geographical variation in prescribing of these agents. Another way to represent this, so we can just see the moving from the left to right, we can see that the GLP-1 agonist on the very right-hand side of this box plot, there's a greater variation between the lowest to the highest prescribing areas. So metformin and sulfonylurea do not show any geographical variation that is significant. So moving back to the answer was, as has been intimated, D, GLP-1 agonists. Another one, who in this conference call has started a GLP-1 agonist? And this would be interesting just to kind of get some of your perspectives. If you could write A or B, it would be very interesting. Great, so 2 persons have said they have started a GLP-1 agonist. I know I have, but I've done so talking to a diabetes nurse specialist. So that's obviously not our practice nurse, but someone who's uncontrolled, had tried 2 agents. I started a GLP-1 agonist with some diabetes nurse support. So it's interesting that 4 persons on the participants have started a GLP-1 agonist. Okay, moving on. Moving on to poorly controlled type 2 diabetes. So how would you define poor control of type 2 diabetes mellitus? I might put that into the chat. What would you say defines a patient with poor control of diabetes? And we all know this, managing diabetes, it's a challenge for us. Okay, so to provide a little bit of help, a raised HbA1c and or high blood pressure. So that's interesting. So we're kind of what we're kind of getting at then is that there's one answer might be that from a glycemic perspective, the patient is poorly controlled. So the HbA1c is high. And another aspect, maybe it's the cardiovascular risk side, which is poorly controlled. So persistently raised high blood pressure or dyslipidemia. There's an awful lot of research on this area that kind of categorizes which is worse for a patient. If you had to choose which would be worse for your health, if your glycemic level was poorly controlled or if your cardiovascular risk was poorly controlled. I don't think it's an either or. We need both to be controlled, but there's a lot of good research that says that focusing on cardiovascular risk is really, really important. So there's no right answer here, but one definition would be that a person's HbA1c is persistently over 7.5%. Other bodies of literature say that a person with poorly controlled diabetes has a HbA1c persistently over 69 or 8.5%. But then those proponents of the cardiovascular risk side of this debate, they would say that obviously those patients who already have an event, a heart attack or stroke, maybe they should be the focus of our efforts. And those in primary prevention, should we think about the patient's cardiovascular risk or Q risk or not? Or just does the fact that a patient has diabetes just place them in high risk already? Certainly looking at the blood pressure threshold and the lipid thresholds and how high they are. So really what I'm getting at is there's no specific definition of poor control in the literature, but it relates to both glycemic and cardiovascular risk levels. So drilling down into this, because this is a research interest of us here in the Royal College of Surgeons, if you just take the 6% of the population with diabetes, and we know that that's going to increase by 60%, as we were saying, in the next 15 years, we know that there's a spectrum of control in HbA1c. So let's just take all of those persons. A few of those persons will have very raised HbA1c. So those with the highest HbA1c. And that spectrum is highlighted if you run an audit in the IPCRN, wonderful tool present on your electronic health record. You'll see that almost 10% of patients will have a HbA1c over 76 or 9.1% nationally. So that kind of begs the question then, should we, in our practice as doctors, should we focus, as we do with the cycle of care, just think about all the patients with diabetes and bring them in every 6 months? Or does something extra have to happen for these 2 patients in our practice, or the 10% who have poorly controlled diabetes? And should our focus be on those? I might tell you a little bit about a study we published last year in the Royal College of Surgeons. This was a systematic review of interventions which looked at which focused on patients with only poorly controlled type 2 diabetes. Our aim was to assess whether or not interventions were effective in terms of glycemic control and cardiovascular risk reduction in primary care and community settings. What did we find? It's obviously a big study. So we looked through 19,000 studies. We pulled out 42 articles, 42 randomized controlled trials. And these patients had very poorly controlled type 2 diabetes, a mean HbA1c in OL units of 9.5%. So overall, these studies had a low risk of bias, and most of them were randomized controlled trials. And the results were as follows. Compared to usual care, which is what we're doing already, which is excellent and very good, interventions that really focused on these in some way reduced HbA1c by about 0.3%, so a small amount. So healthcare interventions have a positive, although modest, effect on HbA1c in poorly controlled diabetes. And they also are beneficial for targeting blood pressure and lipids. So we don't have time to go through all the results. But it seemed that interventions that target those patients, if we focus those interventions on only those with the HbA1c over 9.5%, they really had the greatest benefits. Very few studies looked at professionally targeted interventions. So interventions targeted at me and you to try and support us to manage diabetes. Only one study was professionally targeted. So we thought, based on this, that a targeted approach to diabetes management, focusing on individuals with the very poorest glycemic control, could be a prudent strategy for future management. So I might just give a quick case, and then we'll finish just talking by the DECIDE study. So I'm going to put up, imagine this, your practice nurse has seen this patient and you end up getting the blood results. So this is a case of Mary. She's 62 and she has a medical card, so she's entitled to the cycle of care. And she attends your practice. She has diabetes, she's arthritis, she's low mood and she comes in every month. She's high blood pressure and she's hypothyroidism. The practice nurse has performed the initial visit with the cycle of care and taken the bloods. And Mary's HbA1c is 75. Her blood pressure is 152 over 102, confirmed on a 24-hour ambulatory blood pressure monitor. So let's just have a look at her medicines. So she's on 3 medications: metformin, sitagliptin, a combination drug, and she's also on gliclazide. So that's the glycemic aspect. Then we think about her blood pressure. She's also on 3 medications. So she's on ramipril 5, amlodipine 10, and bendraflumethiazide. She takes a statin, 10 milligrams of atorvastatin, and she's on a few other medications, an antidepressant, some painkillers, and she's on naltrexone. Okay, so I'm going to open this up for chat if possible. What do we do? Where do we start? So obviously, the principles of evidence-based medicine, you're the leader and the most experienced person in this team, so your experience is very important. We use the evidence, which is the ICGP guidelines. We bring the patient's experience, and now we have to come up with a plan of what we're going to do. So I'd appreciate any of your thoughts based upon these blood results. So what are our treatment priorities? So I'll put up that again. So I'll leave the chat open for a little bit and we can see what everyone's responses are. What do you think, where our responsibilities are? So, yeah, we're noting that the HbA1c is very poorly controlled. 52 is ideal, and other risk factors are not controlled. So Susan Smith has brought in the BMI, which I purposely haven't put on this. So that's something we have to consider in the ICGP guidelines. There are other factors we haven't thought of. And she mentions that GLP-1 agonists would be useful. Colette says, thinking about switching. So this patient, Mary's on 3 drugs. So we're going to have to think about intensifying somehow. So maybe insulin or adding another drug, an SGL2 antagonist. Kieran has brought in exercise, lifestyle, BMI. Maybe that needs to be a focus. I think so. And now we're also talking about the cardiovascular risk factor. So there's certainly room in ramipril. That could go from 5 to 10. Dietitian. And David again talks about compliance and possibly insulin is the next step. Okay, and there's an issue of depression. And compliance is in there too. And a 24-hour blood pressure monitor. Suddenly this chart review is getting very complicated. And I suppose this is the reality of these patients who have poorly controlled diabetes. It's not neat and tidy. Yet these are the patients that are the most burdened by their illness, and then obviously have ramifications in terms of the state, in terms of costs. So really, it's great when we get a patient whose HbA1c is doing well and they're flying on their 1 or 2 drugs, but this is kind of the difficult end. So Kieran brings up the issue of alcohol and should she be on aspirin? So for primary prevention. Yeah, that's an interesting point. Susan says no for aspirin. So there is a high cardiovascular risk here. So the benefits of aspirin, again, David says yes. I suppose in the guidelines, in the NICE guidelines and the ICGP guidelines for primary prevention, they would say that aspirin should not be started. But if it was started in the past, maybe it wouldn't be for us to stop it if there were no complications. Okay, so let's just talk about maybe the two sides to this challenge. And I don't think I have a correct answer here, but it's really interesting to hear everyone's answers. So I think one side of this is that there's both poor control of the glycemic aspect of Mary's management and in terms of her overall cardiovascular risk. So I think we need to think about intensifying both sides. So from a medications perspective, I think her medications need to be intensified. We can see that she's on a maximum dose, though, of 3 medications. We've seen in the original guidelines that this would be called complicated diabetes as per the ICGP guidelines. However, if you have access to a diabetes nurse specialist, you might be able to think about switching or adding in another agent before a referral to an endocrinologist. But certainly, if compliance is there and Mary is taking her medications, we need to think about her medications for sure. You could also consider referring Mary to the endocrinologist for this, and that is part of the process because this complicated diabetes patient should be cared for in hospital and in general practice. In terms of her blood pressure medications, yeah, her 24-hour blood pressure monitor would need to be reviewed, and if her blood pressure is up, I think there's no one better in the health system to manage her hypertension than us, and I think one recommendation would be to increase her ramipril up to 10 milligrams, which is obviously the first-line agent for diabetes and is renally protective. Interestingly, no one mentioned the statin. For primary prevention of ischemic heart disease, the NICE guidelines would recommend a higher dose of atorvastatin, maybe 20 milligrams. But again, you'd have to explore Mary's compliance and choice. But medications are only one side, and I think everyone brought up the compliance, lifestyle, and other social issues. So I think it is entirely appropriate that some GPs would refer Mary to a diabetes nurse to the hospital. But I think as an intermediary, the diabetes nurse specialist would work when it's working to its best. They can be a very useful person to run queries by them in terms of intensification options. And this brings in a difficulty, though, because we only get paid for seeing these patients twice a year, don't we? But maybe this Mary needs probably a bit more care, a bit more TLC, a bit more support, and there might be something different with Mary that we need to think about. And certainly getting our diabetes nurse specialist to see Mary would, if possible, would be very prudent. Okay. So that brings up the last issue I wanted to talk about, and this is the DECIDE study. So the DECIDE study is trying to really help us, myself and you as GPs. We're trying to think about these patients with poorly controlled type 2 diabetes and how we can support GPs to manage these patients. And that's the aim of DECIDE. DECIDE is a collaboration between a variety of GPs based in the Royal College of Surgeons here in the HRB Centre for Primary Care Research. We're also working with the Clinical Trials Network because we're trying to roll out a clinical trial with the support of GPs involved. It's also being supported by the Irish College of General Practitioners in West Ren in Galway and the SPHERE programme, which is a structured PhD programme. So in summary, the DECIDE is, I won't go into the intervention because we're going to try and test it soon, but it's basically, we published on this study last year. We've developed a complex intervention that aims to really support GPs to manage poorly controlled type 2 diabetes. And it has a medication intensification side, and it also discusses other actions which GPs can take. It's targeted at us, GPs. We're trying to support GPs to see if we can do anything else to manage these patients with poor control. And we're trying to target it at those patients with a HbA1c over 8.5% or a blood pressure over 155 over 95. We'll test it through a randomized trial and an initial pilot randomized trial, and we'll compare it to usual care. And we'll see if we can improve patients' HbA1c, blood pressure, and we'll collect other outcomes too. So really, this pilot is going to start soon. We're going to start recruiting through with Martha through the HRB Clinical Trials Network. And we're going to need 14 practices. Repayment will be provided. We'll have CPD, we'll develop an audit, and this should be ready to commence within a few weeks of this date. So after this webinar, we've kind of just talked about poor control, trying to support GPs and the challenges, but we'd really appreciate if as many practices could participate in the DECIDE study going forward. So that gives an overview. We spoke about new guidelines from the ICGP in the cycle of care. We spoke about medications and how challenging that can be. We spoke about how they can vary around Ireland. We spoke about poor control of type 2 diabetes and a systematic review we've done in the Royal College of Surgeons. We spoke through the challenges of managing one patient who has poor control of type 2 diabetes, and then we talked about the DECIDE study. So I really wanted to thank you for listening, and if you have any queries, please get in touch with me. Before we finish, I don't know if you have any other points that you want to put up on the chat, and I can try and address now or address later. I will, again, thank you very much for your attention and interaction on the Zoom chat.
Mark, thank you very much for delivering such an interesting and informative webinar, and thanks to everyone for joining in for your concise comments. As a non-clinician, it really strikes me how complex each case is, and it's very interesting to see everything that goes on behind the scenes. Unless there's any questions, I will end up now because I'm conscious that you're all on your lunch break. There doesn't seem to be any questions coming in the chat, only much thanks to Mark. Okay.
Thanks, Martha. Thank you very much.
Thanks very much, everyone.
Thank you.